and I'll turn this over to David.
Great, and thank you, Dixie, for organizing. So we are now the only thing that stands between you and getting to go to the break or your next meeting, depending on what you're doing next, is this discussion, but I think it's a very important one. I'm going to turn this, I don't know how to put that off. All right. Is this on? Can you hear me? Yes. So I'm going to spend just a couple of minutes summarizing, and then we're going to try having an open discussion. And I want to start just by saying how it's really, really striking how important these plenary meetings have been to this whole effort, and to whatever extent it seems like it's helping people in do their work and hopefully moving things forward. Each of the meetings, this is now the fourth meeting if we include the initial meeting in January of 2013 in New York. Each of the meetings, I'm struck, we came in with a set of people and in some cases a set of ideas, and through an intense day-long process and all the preparation for it and follow-up, the ideas changed, new people joined in, and we moved forward. So for example, in the initial conception, or sort of draft of the white paper, there was a much more monolithic approach. This idea of federation, which clearly seems to be, feels right, it feels like it's what's happening and what is going to happen, wasn't so clear, and that's what came out in some way of that first meeting, and also of the big tent approach to try and get as many parties as possible, because the line that's been said, when you have, the thing about if you create a new standard setting group, what you end up is now, even more standards that nobody uses. The idea that if we could actually capture enough of the ecosystem in the discussion, that maybe we'd get some synergy as opposed to dispersion. I think that's happened. I think in the second meeting, where the working groups had just started, the idea of specific tangible outputs of the working groups began to take form of what would be created. The fact that the framework and that we needed consent policy and what the APIs would be and security and framework, and also the beginnings of the idea about demonstration projects. By the third meeting, the real shift began to take place, I think, to being able to see demonstration projects show value, and also that the initial frameworks and APIs couldn't just be on paper, but they had to actually be made usable, right? And that they had to be implemented and used. And now here we are at, in some sense, the fourth meeting, and what I'm really wondering, I want to have some discussion about, is what's the key insight from this meeting? What are we missing? Or what should be our focus going forward? I'm struck that we did go through, after the last meeting, a process of creating this roadmap. And I don't know if, Peter, they were able to get the slides up. But I just wanted to look at this. And actually, so after the meeting in November, there was an effort, there was a half-day retreat that actually, because of storms, actually ended up being virtual, and we tried to distill all the discussions and the working groups and say, what did we need to do? And this is what we came up with. It was sent around to all the membership, and I have to say, sitting through today's meeting, it actually looks to me like it may be missing some things perhaps, but it's not bad in terms of where we're headed. So there's this idea of results, and so there's develop priority products. By priority, we mean, we've heard repeatedly, we can't try and do everything. We're doing a lot. And if anything, we have to worry we might be doing too much. But certainly the goal is not just to add more things to the list, but say what are the priority outputs, and then make sure that we actually, in objective 2, actually deliver working solutions. Because as we're going to get to, if people don't actually have solutions that they use, we haven't really done anything. And the third is support demonstration projects, because we're seeing in the example of BRCA and Matchmaker and Beacon, people be engaged, the potential for real value, and also beginning to see the synergy and the exploration of different models in which you can do this. So I think those are right. At the same time, this next bucket of relevance, and we dedicated time today in our agenda to this, was aligning with the major efforts that are out there. And I think Gil gave a really nice, thoughtful presentation about how human beings are often the connectors, and that you need to build trust, and that if you connect the governance and leadership of different efforts, you can build that trust. And I think that hopefully out of some of the discussions today of the different efforts that we heard about and others that are found through other means, we can build some of those connections. But I think we haven't done as much going down the list on communicating strategically with key audiences and who those audiences are. And that would be something that'd be interesting to hear about, is who is it important for us to connect with? Is it the answer could be everyone and everything, but where we can only do so much. Is it the patients? Is it the regulators? Is it the businesses? Is it the hospitals? We need to figure out what audiences we need to reach. And if we need to be a thought leader to continue having influence, what is the thought leadership we should have? And then I won't comment on the others other than the sustainability of this is both in the people and continued evolution of leadership and participation, but also stable enough funding and organization that we can continue. So I have that up there because this was an effort 6 months ago, coming out of the last meeting, to say what are some things we could do. And in the spirit of these discussions that we have had actually having impact on where this effort goes, I want to open it and ask, what, as people sit here, do you think it's most important for us to do? What are the challenges that we're not taking on that we should, or what are the things we should focus in on? I'd really like to hear from the group, having sat through the meeting, where people are seeing the greatest value and or the greatest gap, that we need to fill. Yes, please.
So Stan Latofsky, LabCorp. I come at this from the clinical lab perspective, and I was encouraged by Ewan's willingness to put a really trivial topic on the table this morning when he talked about CRAM. So I have a trivial one, may have been solved in this group already, but the standards we discussed are pretty well established in the primary phases of analysis, FAST-A, BAM, and so on. Then we get to VCF, which is a little squishy. But in particular, variant nomenclature, which is where we join across all these different knowledge sources. I have a variant. I want to know if you have it. I want to know if Ingenuity has it. I want to know if ClinGen has it. We have HGVS as a standard, which is not, which is also very squishy. So there are various sources of ambiguity in the naming of these things that disrupt our ability to join databases. And a couple of these would include justification ambiguity in the coordinates. Split join ambiguity when we decide whether to group or split apart a complex variant, and in copy number, which is increasingly important, we might even have fuzzy knowledge of where the variant begins and ends. So it would be useful for a group like this to potentially act as a standard-setting body for robust joining of variant databases.
So I think it's a great point, and I hope people, I don't know if somebody's taking notes, somebody hopefully is taking notes of the things we capture. I won't try to do that while I'm moderating as well, but I think that there are 2 points I'd make about your comment. One is, there's a forward-looking approach to that, and I think that when David was talking about like the genome reference as a graph and the challenges of that, the group is thinking long and hard about what's the way that we'd like to do this in the future that will be robust to all future genome annotations and all this. But the point you're raising, which there is a task team on, but I think we need to attend to this, is there is a task team on the existing file formats that, by the way, 99% of all this work is being done on. And getting the balance right of how much effort goes into evolving those and solving the problems they have today, as you're describing a specific set of examples, versus building the system for the future, is actually, I think, an important thing for us to make sure we focus on. I have worried that you can fail both ways, right? In other words, you could say, well, only retrofit or continue to evolve the last generation, and then you never have the thing you really need. And on the other hand, you can put so much attention into building things in the future that you leave behind all the people who are using the last generation. David's sitting there, and I know he's nodding. So I think that you made a really good point, and I think that there is a structure in place to address your comment, but you put a fine point on a particular deliverable that would be helpful.
I'm Jerome Keller. I work on the reference server. From my perspective, I think we should focus more on delivering actual software. So we have some APIs, we have some standards. We don't have an awful lot of software, and not really concentrating on that. So I think if we want to have our APIs get adopted in a widespread sense, we need to deliver, excellent client-side libraries, which are, designed for the language in question, that have specific documentation just for that language, so that they're a pleasure to use. We drive adoption of the API by making it easy to use these tools. So just to sort of point out the obvious, and that's what Ewan said, we need engineers to do this. We're not going to get this software without investing in engineers.
Yep, and I think that's really, I agree completely, and I think that objective to deliver packaged working solutions. It's not limited actually to software, although I agree with you that software is a really critical part of it. It's also, for example, in some of the, for example, consent or regulatory, you can imagine other places where it's a struggle for people not just, to go from the principles to actually implementation and being able to offer working solutions. And Brad Margus actually has this concept, which I think is of sort of the startup kit for, let's say, he thinks of it more for, let's say, a disease group that wants to, like the project we heard about, Autism Speaks. If a group wants to go out and, for thousands of diseases, there could be, get all the families together, collect the samples, do the data, phenotype and genotype data, analyze it, make it available on the web. How do we make it easy for people to do these things, not take it over for them, not become monolithic? So that's intended by Objective 2, software specifically, but even more broadly. I think the question of how that happens is something, I'm again taking away as a key, might be the shift we remember from this meeting, because we've been very careful not to try and reach in and take over all the things that people are doing in the world, both because it would fail and because it would be overreach. So we're a body that's trying to bring people together and set standards and all that stuff, and how the software gets created is not entirely clear. Not to say that there aren't ideas, but I'm saying we have to choose a path. I think the funders, frankly, are there. I think the companies in the room might be willing to participate. I mean, there's a lot of ways, a lot of resources we could bring to bear. The point is very much correct. I don't think we're going to solve it here today, but I think that if we don't deliver software and other such useful tools, then everyone will go do something else because it's too hard to use our stuff. I'll just keep moving around the room. Yes?
Yes, Terry Vrijenhoek from Utrecht again. One of the things that I've been missing, especially in the morning program, and that maybe intentionally, is the perspective of the patients or even the citizens. And I can imagine that at this stage that may not be relevant, but if you look at Objective 5,
yep,
you want to eventually communicate with some of the key audiences. Would it actually not be that you'd like to involve or engage with those key audiences, and that one of the key audiences is actually the patient? We've seen a presentation from Autism Speaks, but I think we want to go a little bit beyond patient representation and engage with the actual, maybe not even patients, but healthy individuals. Can we, for example, look at the DIY community that is growing quite rapidly all over the world?
Yeah. So, I mean, I think that I liked Ewan's framework of, what's got the good, the bad, the ugly, or what have we achieved that we wanted to and what have we not. What's interesting to me is that this effort started very much with the idea that it was going to be patient-focused. And as we have just, people have shown up, they've done stuff. We at the meeting in London 15 months ago, there was a whole section on patient engagement, and it just hasn't really happened. The other thing that's interesting, doesn't mean it shouldn't happen. I think your point is correct. I'm just saying it's, this is very much an organization where the people who stand up and lead and act, David's description of people just coming and doing the work, and that hasn't quite taken off. But I think it's absolutely critical, and that is what's meant by, Objective 5 in some ways, communicate with key audiences and engage. We have had some thin interaction. I mean, it's not nearly what we should have. For example, there are some organizations where we have some of the members of the Alliance are themselves large disease advocacy organizations. There's groups like Global Genes, which is a rare disease umbrella group, for example, that has developed a pretty strong engagement. But nonetheless, the point is very well taken that both the level of patient advocacy, which are organizations, and patients, we haven't had nearly as much connection as we thought. I think the other thing, I drew this picture here. I don't have a whiteboard to draw it on, but there's a continuum that Ewan sort of described of research and clinical, and that's like one axis. But there's like another axis, which is like the world out there of people who neither identify as research or clinical. They're either patients, or like organizations and businesses that aren't themselves researchers or clinicians, but interact with or benefit from. And I think that one of the interesting things, I would never predicted a year ago that we'd have something over 100 companies involved, right? So it's 320 organizations and 5% are disease advocacy groups or something. That's like 15 or 20. And then there's over 100 companies. Whereas like when we began, there were a number of patient advocacy groups and no companies. And so I think that's another group of stakeholders that are in this room that could play a huge role in both creating things, but also the comment John Madison said about engaging vendors and getting uptake in the community. Companies often and organizations do that. So I think there's two communities. One who's actually is some in the room today, companies that will offer services, make products, et cetera, that will be involved in this, and then the other is the patients themselves, and we need to engage them more. I'll just Bartha, and then I'll go over here. We'll just keep bouncing around.
Yeah, in terms of current needs, the Regulatory Ethics Working Group is establishing an accountability. I think you brought up a question about authenticity or validation of researchers and moving away from the culture of caution that Graham said to one that is built on trust, but then effectively sanctions any kinds of breach. So that is the accountability task team. We also are building a lexicon. We're finding with the European debate on the directive/regulation that the Americans are talking de-identified, the Europeans are talking pseudonymized, somebody else is talking encryption, and what does it mean? Can you really share data when different language, privacy language or security language, is used in different documents? So we're trying to build a common lexicon. There's also the two ends of the spectrum that are missing, a pediatric task team that is starting today. There's going to be one built in the future called Aging and Cognitive Impairment to look at the more vulnerable groups, but how not to exclude them and make sure we include them. But then I have a challenge. Why use software or not use software? We just heard we should use it and build more software. Why not, when you're applying for funding, mention the framework to your funders as a philosophical position that you as a researcher in your institution or your company or whatever is going to follow. And if you build these tools, if we don't use them, they're going to fall into oblivion. For consents, I've seen 2 consent forms now say we're using the generic template that's on the Global Alliance as a starting point and then customizing it. So if we do build these tools, you have to start using them, improving them, customizing them, and I think that way, the interoperability from a policy point of view, we can really move forward. Because if we don't, in 2 years, if we don't see them being used or mentioned or becoming the basis of an application, then why build them?
Well, I think not just why build them, but one of the things that I have written here, I'm going to come to it, is how do we measure our own success? And I think that one very simple way to measure success is it's all being used. Right? So in other words, if the APIs and there's software and they're being used, then we've done something. And if they're not being used, then we've done nothing. And similarly, we can put up frameworks and offer language, but if they're not being used. And so that is one of the things we need to be thinking about here is how do we actually how do we make, things that will be used? Because if we're not used, we're not having any impact. Over here.
Hi there. My name is Mark Bartlett, and I'm from a precision prescribing startup, Genix. We've just started doing a research project into the value proposition around precision prescribing pharmacogenetic implementation into the clinics, where we're assessing different stakeholders in the UK. We've just started the interview process, and one thing that's just become really clear, and this relates to Objective 5, is that we really need to start communicating, and the key audience, in our opinion, is the physician. Patients are obviously going to be the people who will be benefiting from implementation of genomic data. However, the physician is a linchpin that holds together the regulatory bodies, hospital groups, payers, patients. They're always going to be that position. So I really would recommend that we start communicating more engaged with not just clinical geneticists, but it's actually cardiologists, gastroenterologists. There needs to be a really big movement, or we can do it in a smaller fashion by reaching out to Royal Societies to really engage these just everyday clinicians to really understand the power of genomic medicine. And I think that's where the value will start then precipitating into the regulatory system, the payer system, and the patients.
Right. I mean, to offer one comment on that, I think that whenever genomics is in the position of trying to, there's often over the years I've been in genomics, the phrase where we have to convince them or show them the awesome power of genomics. And I actually think what we need to do is demonstrate the value of genomics. Because there is often an imperative from organizations or companies or academics or research. We want to show them, we want them to believe how valuable what we've done is. And I think that the really key question we have to ask is what will actually demonstrate how valuable it is. And I think that we have heard examples. I think the BRCA challenge will be of great value, the output to patients and families. I think that the matchmaker, again, can lead to diagnoses. And I think that I would turn it around and say, like, what are the things that we can do that will actually convince, will demonstrate to others that society, physicians, patients should actually want that.
So in the rare disease world, patient organizations have been great drivers and great allies and great advocates for data sharing. And so we have, in IRDIC, Eurordis is very deeply involved. So Jan Lecam is the head of one of the scientific committees. Virginie Yver sits on the executive. And also the Genetic Alliance with Sharon Terry have been just powerful advocates for data sharing. So I think getting back to the previous speaker's point, Genetic Alliance would probably benefit and it would also advance the agenda by engaging more with those groups. And certainly I'd be very happy as the IRDIC dude to try to work together and get the patient organizations that are involved with IRDIC really talking to you guys or do something jointly with you guys.
I think you're exactly right. I think that there's something that hasn't happened that needs to happen. The reason I say that is, like, Sharon was at the original meeting and has been a big supporter of this effort throughout. Again, Global Genes, there was a connection. You're here today. There's a connection, but like it's not that the conversations haven't happened. What is the kindling is there, but it hasn't sparked into fire. And we have to actually, maybe it's a bad analogy, but it hasn't taken flight, whatever. And we need to figure out how to make it more real because it hasn't happened quite so much.
Maybe we should talk after, but doing something jointly involving those groups, I think would be really desirable.
I totally agree. We'll go over there.
Yves Moreau, University of Leuven. A small thing for the people working on ethics, and that follows up on the remark about accountability, is that I'm a bioinformatician. We work with clinical genomic data, and something we're missing is a code of conduct for non-clinical researchers handling clinical genomic data. Because our people are not trained at all. Often there are big cognitive biases, like lots of cancer genomics people don't feel like they're handling patient information. There's no training available for us. And I don't think it's a very big thing, but it would be very good for us to train our people and say, okay, this is what's expected, a minimum of information about privacy, about deontology, about ethics, that they can really pick that up quickly and behave in a responsible way. They don't mean bad, but
actually,
I
think it's a great specific suggestion. I've seen that myself, where people are brought into it because they're interested in data or they're interested in some new technology, and they don't just have the opportunity to learn. I think the other group of people who feels that way are the doctors that the gentleman who was just commenting over here. The doctors I find who aren't genetic doctors, I am one of them. I was an endocrinologist before I became a genetic researcher. I wasn't trained as a clinical geneticist. And I'd find among my colleagues, they'd say, we don't want to do a genetic test. It raises all sorts of ethical issues. And you'd say, well, you would do something else that could find cancer. That doesn't worry you, but you're worried about you might find, so there's a lot of mystique or genetic exceptionalism that training about just what are the implications or not of doing genetics could be helpful.
Hello?
Yep.
This is Dennis from Seven Bridges Genomics, and I'll make a macro point. It's the same point I made in the previous meeting. So we do software and we do graph genomes, but basically our belief is that people don't share not because they lack tools or software, but because the incentive structures are wrong. Tools and software have a way of just appearing when there's actually a marketplace and incentives for sharing. Protesters organize across the internet. People use FTP sites, torrent sites, illegal sites when they want to share. So I would encourage to not think of this as a software or API problem. Those things certainly will help make the transactions more smooth. But I believe the elephants in the room and what I don't see being addressed is how do we build an incentive structure for people to share? Because if the tools being developed are not being used, it's not because necessarily tools are bad, it's because people just don't want to share. So the question here is...
So what's the answer?
Yeah, the answer, okay. So would researchers be willing to share first and then publish later? Because we don't see much of that happening. We're not going to call out individual names. And what structure would you need from your government funders, the NIH, and the national governments so that your incentive structures are aligned with a sharing first opportunity? And we believe we're basically stuck in a multi-agent low point in a Nash equilibria. How do we provide the catalytic energy so we all go to a higher Nash equilibria where everyone is sharing?
So I think the answer to that, one answer to that, so first of all, I have to say, having been in meetings like this for 20 years, when the answer is we need to educate them and we need to change the, I'm just saying we need to change the world, I actually just, you can't go anywhere with that, because our ability to change the incentive structure of the world or to change the belief system of physicians and all that is limited. Having said that, I think that what I've seen, at least over the years, is the best answer to your question is to actually demonstrate value. Okay, so the way that you actually drive incentives, and so one example, because I don't think actually when you said people don't want to share, I think people just as in Seven Bridges or in academia or any other organization, they actually seek their own, what their incentive structure is. So yours might be to say we don't need APIs because we already have them, or I'm just teasing. But what we could say is that everybody wants to maximize in this field their productivity, what they contribute. So in the case of human genetics, people weren't actually sharing years ago, and actually, although they may not share openly on the web or whatever, there's actually the rise of big consortium publications and publications with lots of authors being done before publication, which is what you're saying you wished would happen, came from people realizing they couldn't make discoveries unless they worked together. And then actually, as you said, when you create the incentive structure, they came together and did it. And a lot of this effort actually came out of researchers and clinicians who were already sharing, who were frustrated by the lack of tools and standardized consents and all that, had the incentive and wanted to come solve some problems. And I think we cheer and celebrate any way they get solved. That's why I think we shouldn't define that our goal is to make the implementations. So there is this tension of, we could say our job is to make all the software, make all the databases, build all the tools, and then we're coming up with a monolithic solution. I think ultimately we should lower the barriers and create the incentives wherever we can. One way to do that, it has been where we saw things that weren't happening, try and create them, but if they happen naturally, the world takes off and builds all the tools, we could de-emphasize that. And the other, most of all, is to demonstrate value. Because I think that when we show that you can make medical discoveries or improve health, something, again, like the demonstration projects we have, if the average person who has a BRCA test gets a better result because of the BRCA challenge, that will drive a lot of data sharing because people realize they can do that.
Just to add some nuance to that, I think when people think about sharing, what they really have in mind is they get to use other people's data. They understand the value of being able to query their sample with other data, but they don't get an immediate benefit by sharing their data at the get-go, and that demonstration of value doesn't actually happen the way you described it. So I already had the patient going through the system. Why should I share it now? I've already analyzed it with the existing data. So it'd be great to have more. I think there are lots of smart people. If Global Alliance would be willing to act as a lobbying organization to talk to governments and these larger entities, I think they would listen to you. I think it's a very respectable group of people, and I think you could think more ambitiously and become a international face for the genomics community and drive incentives.
So we could be a thought leader, and I think that if we had clear things that we believe we should say that would increase the incentives, and I want to let other people chat, but I would say, for example, the discussion you're describing, there was a meeting that was held by the BD2K NIH group, you may have been there, that some of us were at, where there was basically half the meeting was on exactly what you described. Okay. How do you create the incentives for sharing and the like? And we were there, and this could be sort of a thought leadership thing. You just have to have very good things to say about how to create those incentives. And sorry to keep you waiting.
I think we agree that we're moving into the implementation phase now, and I'm delighted that you just talked about the demonstration of value. I think it probably means that in relation to Objective 5, we probably actually start to need to be more professional and actually either have a communication and engagement working group or something like that that actually allows us to demonstrate that value that then will bring more people into the initiative. Because I think we now are at that phase, I think, where there are things that are going to, over the next 6 months, develop. And just we need to have that ability to actually demonstrate value.
So we actually have a secret weapon in this project, which is sitting in the back, Tom and Kyra and others from Friedman Consulting, who are world-class communications people. If you ever wondered why, for example, 2 years ago, the rollout of the Global Alliance went so smoothly, is we actually have very good people who are very mission-driven with us, who are helping us with that. I think they've in fact been champing at the bit in some way. I think what we need to do is figure out what's our message. Yeah. What is the message along the lines of, is it about we need funding for software, or is it about, David says yes. We have some people say it's about funding for software, others should say it's not the software, it's the incentives, others would say it's education. We have to figure out exactly what message we think we should send, but I think that with this group and with that we do have some very good people to help us, we could do that. We just have to figure out what the message is. Heidi, are you waiting or just standing over there?
I'm waiting.
Okay, go ahead.
So going back to your first question about what have we done well and where can we go forward, as I look back a year ago, there was a lot of focus on don't reinvent the wheel, identify gaps, build standards for interoperability, develop frameworks, and I think that we've done a really good job. There's still lots to do, but thinking about reinvent the wheel, as I look at the BRCA challenge, when that was proposed, I could have stood up and said, gee, we're already doing that in ClinGen. But the truth of the matter was we were doing that, but in a small scale within primarily the US. And what I saw as the incredible benefit of taking that on as the Global Alliance is a massive international effort that I think has really brought the community together in ways that I don't think I could have achieved just within the ClinGen framework. And so one thing I might think about, instead of saying don't reinvent the wheel, really think about how to make the wheel faster and find the actual projects that are really doing very well in certain areas. But how can we, I think this organization has grown well enough that now we can think about identifying the things that are working well and trying to scale them and connect other groups to do the same thing elsewhere. And
I think that's a great comment. I think it's another way of saying demonstrate value. Like we sort of have to pick what to do, and if we have the trust built that again we're not stepping on toes, we should do whatever it is in the next year or two that will, I think, that we can do to help, that would demonstrate the value, that would, when Richard says, they've done as much, if not more, than anyone in the world, and hit the Baylor group in terms of the clinical genomes, and they say, this is helping us, or this isn't, the thing that, we're not as challenged by the technical piece, but we think, matchmaker, I don't want to quote, misquote you, Richard, but, matchmaker on steroids or whatever, is what we need. That's saying, here's something that's working, and maybe we can actually really ramp it up. And I think that will address some of what's the incentive for sharing, because I think that people don't have one sample, and then they're never going to do this again. They don't have one, they're going to be in this for a while, especially if they're like diagnostic or clinical. They're going to do a patient today, tomorrow, next week, the week after, the month after, the year after, and if participating in a network allows them to do their job better, it's not for altruism, they will participate, I believe. Steve Lincoln.
So I'd love to know your thoughts. When I look at the clinical and translational people in this audience, I think most, correct me if I'm wrong, folks come from major academic health centers, again, scattered around the world, which is wonderful. Statistically speaking, at least in the US, and I know it varies country by country, most healthcare is actually delivered in the community health setting. And I think the number is about 85% by dollar spending. And that includes most cardiology and most oncology, so it's not just primary care. My question for this group is there a way we can take what we're learning about trying to get this implemented in the academic healthcare setting and push it down into the rest of the system? No,
I think that, in fact, it's a really critical point that, like we have here LabQuest and LabCorp, and we have Quest. I'm not sure if they're here, but like most, and I don't know the international scene well enough of who does most diagnosis, and obviously most patient care is not done in centralized settings. And so we could actually win the battle and lose the war. You know, that's actually what I meant when I asked John Byrne, you know, how do you imagine this happening? Is not just in specialized centers, but like there's what's called the second translational gap, or somebody has called it that, where the first translational gap is someone discovers something and you have a treatment, and can you make the treatment or the diagnostic? The second translational gap is, having made it, will anyone use it? And the history of medicine is often no one uses it. And actually what's interesting, it underlay my question, my answer to demonstrate value, because in the healthcare world, actually, you know, what often drives these things is like the New England Journal of Medicine paper that actually shows the combination of the New England Journal of Medicine or Lancet paper that shows patient impact and then reimbursement, right? Like if you have something that shows a lot of value and then someone will pay you, so there's economic value, all of a sudden all those doctors will use it. And I don't know how it works in other countries as much, but I bet it's not totally different.
Right, but just to wrap that into Dennis's point is, you know, doctors, particularly in the community health setting, don't get paid to share data.
Right.
Right.
Although it's interesting, and again, I don't want to go beyond, but like there are organizations in America, and again, I don't know the international scene well enough, but ironically, like there are these organizations like IMS and others that have data on a huge proportion of the American population, and the reason is because they process the transactions. And there are other big data organizations, you know, like Flatiron Health has managed to get a lot of those other organizations to share information. You have to create, that's where you have to create a business model, you know, that can actually draw people in. So it is an interesting chicken and egg problem to say, is the problem that we don't need to worry about the APIs, we just need to create the incentives, or is it that, you know, you need to, you know, find that thing that will create the like maybe the businesses will find the incentive, but they don't actually have the technology they need. It's hard to predict which way it'll go.
Peter Yu from ASCO. So one of the problems in the clinical world over the last decades is we have evolved into two paths. We've evolved the clinical care path and the research world path, and they've diverged apart. And so you have data that is structured in the research process, but it's very inefficient, and you have routine clinical care where the data is just messy and unstructured. And so we've created two imperfect systems, and what we're challenged now is to see if we can create one healthcare system that serves both purposes better, a rapid learning healthcare system. What I've heard in the last 2 days is very encouraging, but I also hear, again, this recapitulation of there's the research world, and then those clinical people out there, we know they're out there, we're not quite sure what they're doing, but they're out there somewhere. In every country, it's a different healthcare system, so it's even more muddy. And I think one of the questions for the Global Alliance is it going to do its great work, which is great work on the genomic research side, and hope someone figures it out on the clinical side, or are you going to help the clinical side develop the same thought processes, the same structure, the APIs, the shared databases, all the things that you're doing that we need on the clinical side to help us move to advance that, so you'll be able to get access to the clinical side. That's one thing. The other thing is the approaches are somewhat different, and you can learn from that. So, for example, the consenting process in the United States, one is allowed to use data without consent if it's acquired in routine operations and for quality improvement. And that is in fact how ASCO has constructed Cancer Link, is we have the data that's obtained for routine care, and we develop applications that will drive quality improvement. So that gets us the data. We then give the patient the chance to opt out. So they don't want to have the secondary use, they declare that, but actually, technically, we don't even have to ask for that. I mean, we'll ask for that. But technically, once you have the data acquired for routine health operations, you can then de-identify, aggregate, and use it. So there are different approaches, but I think that we need to sit down and talk. You have this big data security group and privacy group, and there are issues on the clinical side that probably inform each other. No, absolutely. I think that I think it's an excellent point. I think that the Alliance, again, if you look at it, has actually a minority of people of organizations involved in research, but different talks show different biases. I'm saying some people clearly come across, and they might be on the research side, and they might say, oh, I see these as phenotyping centers, but actually other people who are up on stage are people who run health IT for different organizations and everything in between. I think that the challenge you describe of the research world and the clinical world, and how different they are, and it looks like, in many of the talks, David Hauser, the talks, the virtuous cycle between them, there's like a very sharp
boundary or a very deep divide or whatever phrase you want to use between them. I think the fact that we're actually having this discussion and there are different organizations in the room is at least new to me. It's a broader group of people discussing it than I've seen. But on the other hand, we certainly haven't solved that problem. I think this is a conversation of the sort you're describing. I think honing in on whether and how we break down that barrier or create a shared learning system is something that not every organization even wants to see happen. Do you know what I'm saying? It's like some want to see that. The research and the clinical come together, and others think, you know, one's a regulated environment, one's not. It's a complicated challenge, wouldn't you agree?
But I agree. I think it will happen. The question is whether it happens faster or slower, and obviously everybody in this room wants it to happen faster, so I'm just suggesting
I'm agreeing. No, I'm saying I think we've
I
constructed a room in which that conversation can happen, and we should continue it. All right, I'm going to have to stop. I'll take one or two more. Bartha's going to kill me. She told me I had to stop at 4:30 because she has a meeting starting. Jacques.
Okay, Jacques Beckman from the SIB, Switzerland. Coming back to this issue of relevance and demonstrated value, it seems to me, and I just throw this, it seems to me it would be useful to have a catalog of examples of demonstrated value, because when we talk about it, we talk about BRCA1 challenge, we talk about matchmaker, but we talk about a limited number of examples, and most of the time they're in the realm of genetics, or medical genetics, and I think we should try to get outside of it, and such a catalog would be helpful. Because in real life, in the clinics, clinicians often are skeptic and conservative, and we lack arguments to demonstrate, you know, they want to see it. And the second thing is, it might even incite people to think of new ideas and new applications, new developments. This catalog for me is missing, and I think it would be useful if J4GH would build it.
Yeah, no, I think that a lot of the, again, of showing value and building the case for where they're, and I think that coming back to the question of engaging with clinicians, a clinician-focused view of where it's valuable, not just
I'm talking
research.
about not research. I'm talking about clinical value, clinical utility.
Yeah, absolutely. It's a good point. All right, last comment.
Okay, this is quick. Melissa Handel. So I just wanted to mention how I've been hearing the word curation throughout all of the talks yesterday and today, and I think that the Global Alliance has done an absolutely amazing job at, you know, just rallying an enormous amount of, you know, volunteer effort to actually curate this data. But as somebody who works in the biocuration area, I also have deep concerns that we aren't coordinating these things. And it's great that we have all these efforts to try to, you know, curate the actionability or the evidence associated with particular variants. And we heard earlier about the need for annotation consistency for transcripts. But I think there's a lot of algorithmic and technical solutions for combining machine learning methods with manual efforts, and for actually evaluating the manual efforts to make sure that we're consistent across all. And so I think this is a gap that we are now reaching here in the Global Alliance, and the Global Alliance can really help us come up with some strategies and some tools to help standardize the curation efforts that are so valuable for everything that we do. So,
okay, thank you. Another good point. Wait, okay, I should stay here? Okay, wait, okay. Can I thank, okay, I'm a little afraid of what's going to happen. Yes.
Real quick, I know we're dwindling towards the end, but as we announced earlier today, this is David's, he's stepping down as being the chair of the Global Alliance, and I think, transitioning, I should say. Peter Goodhand and I had worked with him for a long time. For those of you who don't know who I am, my name is Anthony Philippakis, and I'm a cardiology fellow at the Brigham. And once long ago, when I was a med student, I worked in David's lab, and as he was putting the Global Alliance together, he was kind enough to pull me into it, which as a very junior trainee has really been an honor. And I think Peter and I just thought we would take a moment to thank, on behalf of everyone, David's contributions, having sort of been on this road when it began in September of 2012, and watching his leadership and the way he drove it in a lot of non-obvious ways, I think there were three things that I'd really like to commend him on that I know he was not thinking about in the beginning when this started. The first was really to drive this towards a much more inclusive, federated model. And then the second was really to engage a variety of different stakeholders, whether they be research or clinical or tech or healthcare, and patients and doctors. Again, a real expansion from the initial conception. And then the final thing, which I think was maybe the most important, is, again, as someone who trained with David, his drive towards to be the one to want to do things, whereas realizing that sometimes what's really needed is to be the one to enable others and to set the standards, and then to enable the community to do it as a whole. very unselfish, and I think we're all better for it. So on that note, I'd like to say thank David for all of us, and I think Peter also would like to say.
So July 3rd, 2012, at Tom Hudson's suggestion, I went to talk about a crazy big idea, the climbing of the mountain that Ewan showed us. I had a meeting at the Broad, and I was walked to my cab to go back to Canada by this guy in his stocking feet because his new shoes that he'd walked to work in didn't fit. So the start of the Global Alliance was David walking me to the car. The next 2.5 years have been me usually walking him to wherever he was going, because the only way I could get that last piece of information I needed to make the next thing happen was by walking alongside as we scurried to the next thing. But I just want to reinforce what Anthony said, that this sense of, I think David put it in the beginning, every time I go to a meeting, people talk about the problem. People talk about the lost opportunity. We've got to stop talking about it. We've got to do it. We should do it big, and we should do it inclusively. This thing would not have happened without David's vision and without his energy. And so I think for all of us, we'd just like to thank you for the Alliance.
So thank you very much. Actually, my last thing is thanks. So first of all, I just want to be clear also, Tom and I work out exactly what the transition is of the chair, but I'm not disappearing on you. I care about this way too much, and you're not getting rid of me that easily. But I think it's important that we have rotation and leadership, otherwise these things get stale, and so that's why we're doing it. Quick thanks before we let you out of here. One, also just the ideas that were said in this last session were captured. We've acted on them before, we'll act them again. We're sort of not dilating on any of them, but we did hear what you just said in this discussion. If you have others, send them to Peter or whomever, but probably Peter's a good point of contact. Other ideas prompted by the meetings. I want to thank the program committee, Tom and the other members, he listed them. I want to thank our local hosts, and Johan Den Dunnen at Leiden University Medical Center connected us here and has helped us and with local organizing. I want to thank our sponsors. They were up before. I'm not sure if we have them up again, but it was very generous support. That was it. Before we follow on Twitter. We were been benefiting from generous support, all the speakers, but I want to just finish with where I started this last section, which is with each of you, because this is a big problem. You can look at it from many lenses, and it's hard to get it just right, but the reality is that many of us went to meetings for years on these topics, and nothing actually happened. And that's why we got frustrated, and that's why we organized this thing, because David's nodding his head, because he and I were at so many meetings together where everyone would say, well, we need to educate people, we need to create incentives, we need APIs, we need people to change, but nothing actually came of those meetings. And what's really remarkable is that out of just getting people together and talking about it, work happened. You know, tools and methods and frameworks have been created, projects have been accelerated. The thing we have to realize is it's because each of us does it. Each of you does it, those 750 people, the 320 people in some organization who signed up. And if we don't continue to do it, it will stop. And so that's what we should all be afraid of. It's not, the best is the enemy of the good. But so we can't, we may not solve every problem, but we have a whole set of initiatives that actually have gathered some momentum that will make a difference. And I see it almost as like an airplane that's going down the runway and its nose is up. And if it can just fly around, then we'll really be doing something. And if it just sort of putters out, then we'll have accomplished nothing. So I hope everyone goes home, doesn't sleep well, feels a sense of urgency and accountability for making this thing happen. And if so, then we'll have done our job, and we'll meet again sometime soon and hear about the great progress since this time. So thanks to everyone. Take care.